So my name is Julie McCartney and I'm the Clinical Effectiveness Lead for Drug Harm Reduction and mainly cover the east of Scotland. What we're seeing in terms of the people who die in Scotland of a drug-related death, what we're seeing is polydrug use is the biggest contributor to death. And when we use the term polydrug use, all we mean by that is using lots of different substances potentially in a 24 to 48 hour period. You don't have to consume the substances at exactly the same time, but just by the fact that they're in the body, they're mixing together and they all kind of contribute to physiological problems within that patient. So what we would look to, I guess, make people aware of is mixing drugs which are central nervous system depressant drugs. So the most common drugs that people are mixing that are resulting in drug-related death at the moment are opiates or opioids, and that's things like heroin, methadone, cocodamol, tramadol, any drug that's codeine or opiate based as a central nervous system depressant. What we're finding in Scotland is we have a really, I guess, tumultuous relationship with benzodiazepines. So benzodiazepines are very commonly taken alongside opiates. And benzodiazepines at the moment, what we're finding is it's mostly illicit benzodiazepines, so street benzos as they're quite commonly known. So mixing street benzodiazepines, people may call that diazepam, but more commonly now what we're seeing is, I guess, what we would call novel benzodiazepines. So they're not prescribed in the UK, they're basically manufactured by people who are looking to obviously put them into the drugs market to sell them illicitly. And quite often contain benzodiazepines that are quite dangerous, they're very potent. Often the manufacturing of these tablets is very poor quality. So we find that in a batch of tablets, we'll find that lots of the active ingredient is maybe in a small number of those tablets and a lot of the tablets don't have anything in them. So people are taking tablets with no real conscious understanding of actually what's in them and how strong each of those tablets may or may not be. So they run the risk of people taking more because they don't think they're very strong. Mixing that with opiates, those two together are a really, really strong combination. Both of them act on the central nervous system to slow down breathing, which ultimately can result in somebody's death. Two other drugs that we're finding really commonly mixed with those substances as well is gabapentin or gabapentinoids. That includes two types of drugs, so we've got gabapentin and pregabalin. Again, very commonly resulting in central nervous system depressant when taken alongside other drugs. And finally, the fourth kind of most common drug we're seeing, and a big rise in that at the moment, is the use of cocaine. So opiates, benzodiazepines, gabapentinoids and cocaine. Those four drugs are very commonly used together and are most commonly causing drug-related deaths in individuals in Scotland. So obviously the call will come through to our ambulance control centre, and the calls are graded on obviously severity of risk to the patient. Obviously overdose is a high risk situation, especially if the patient's not breathing. So obviously dependent on the patient's current presentation, and we rely quite heavily on what the caller tells us. So we always advocate that anyone calling the ambulance service for a suspected overdose quite clearly tells us that they think the reason the person's unwell is because they've taken drugs and that it could be an overdose situation, especially if they have naloxone on them, because the call handler will be able to talk to them about how to administer naloxone. So that's something we're trying to get across to the public, that piece of education about if you're going to call us and you think it's an overdose, make sure you tell us, and it allows us to act as quickly as we possibly can to get a crew along to come and help. So obviously on arrival, the paramedics and technicians will obviously do their job in terms of clinical interventions and providing medical treatment. And probably the most common form of treatment that we would administer for an opiate overdose, so that would be potentially somebody has overdosed from their use of heroin, or potentially over-the-counter opiate medications that could well be prescribed by their GP. So the most common forms of treatment that we might look to provide would be the use of naloxone, which is an opiate overdose reversal drug, and oxygen, because often when people are going through an opiate overdose, it's the issue with their respiratory system that causes greatest concern. So basically the person isn't breathing effectively, which means a lack of oxygen coming into the body, which can then start to cause obviously issues regarding respiratory depression, which can lead to things such as cardiac arrest, which are obviously very dangerous and can ultimately lead to somebody dying. So in terms of the ambulance service response, when we treat somebody for what we call a near or non-fatal overdose, what we've built now into our recording systems is automatic flag criteria that if these flag criteria are met, means that we will automatically refer that patient to their local health board. And in Fife, that information goes to ADAPT. So we have a really seamless pathway between the ambulance service and ADAPT's non-fatal overdose outreach team. So what happens basically is, to kind of try and keep it as easy as possible, we go out and we treat a patient for a heroin overdose, and we administer naloxone to that patient. By us doing that, it automatically flags that patient as being at high risk of a future overdose. And because of that, we want to make sure that that person is connected to a community service like ADAPT, who can then follow that patient up in the community and make sure that they're okay. They can offer them support, they can reach out to them, and it basically means that that person is not just left after an overdose with no help and support. It's really, really important that we engage that person in treatment. Now, we know that engagement in treatment is a protective factor against drug-related deaths, so we want to make sure that every patient that we treat who's at high risk of a future overdose is automatically connected to a community service, and that's exactly what happens in Fife. The information comes from the ambulance service, it makes its way to ADAPT, and ADAPT basically reach out to those patients, check that they're okay, and offer them that connection of support. And it's really, really super important. And that relationship between us is one that works really, really well. We make vast numbers of referrals every month, and these patients are obviously followed up by ADAPT. What we also have is a side pathway to that. So the non-fatal overdose pathway really highlights patients who are at high risk of future overdose from their use of opiates or benzodiazepines. But what about those patients who don't use those substances, but they use other types of illicit drugs and are equally at high risk of harm? We have a pathway that means that on scene, when we're with that patient, the ambulance crew can chat to that patient about whether or not they think a referral to ADAPT would be useful to them at that time. So we can do that from the scene with the patient's consent. We can actually have a conversation with ADAPT, tell them about what's going on for that patient there and then, and ADAPT will then take over that care and that support of that patient if they're willing to kind of allow ADAPT in and offer them that support. So really, whether it's a near or non-fatal overdose on scene, or somebody is having a kind of problematic relationship with their use of substances, both of those situations we work directly with ADAPT to ensure that patient gets the ongoing support that they need.